My name is Murray Martin, one of the haematology consultants here. Zoe and the team had asked me to give you a bit of a review of haematology in the ICU environment. This, believe it or not, was Dr. Flint's summary of his reciprocal talk to us about a year and a half ago, just before COVID kicked off. And his fine wise words were that to the haematology population, the ICU was bad for you, but it might be good for you. And I allegedly owed him a beer, which I do think I do. My summary post-COVID is that I still think that ICU is still potentially bad for you, but it can be good for you. I still owe him a beer. Beer gardens now actually are open, and Jenny and JT nearly made it to Christmas #1 in the middle of all the madness. And on a serious note, it's been a really difficult year for you guys in particular. It's been horribilis and all that. And I think just basically from the haematology end of things, thanks for putting up with us in the middle of it, because I literally and we as a team cannot do what we do without you guys still being able to provide us with intensive care support. Certainly the team here in the Royal were incredibly obliging whenever we still had to crack on with the stuff that we couldn't leave alone during COVID. So it sort of put everything into perspective about how reliant we are on you guys to be able to actually do what we do. As haematologists, we have a role of investigating, diagnosing and managing conditions, but we also manage hemostasis, we manage blood product support, we do a lot of research, and if you look at through the UK, there's about 130 billion plus hematological results are generated in a year, so there's a lot of disease that potentially comes from that, and a lot of conditions that need to be sorted out, and quite a lot of stuff ends up coming your way. I think with regards to the basic level, what kind of stuff that you get to ITU, it's either a de novo presentation of a bad disease that comes in a mess, or it's someone that we've already had with the disease that started intensive chemotherapy treatment and has ended up with related organ failure. And certainly in the Royal at the minute, we've got 2 patients one with acute leukemia who's got multi-organ issues, and another with acute leukemia that have been in remission and has just gone through an allogeneic bone marrow transplant myeloablative regime and is currently in a bit of a state in the department. COVID's made a huge difference to what we do and how we've done it as well in the last 12 months. So literally, it really did hit home that I cannot run a transplant program without access to intensive care. Hierarchically in the UK, we come up as a group of transplant physicians with a regime that made sure that those that would otherwise die without autologous or an allogeneic transplant went ahead and still had it, but that was very much dependent on the provision of local services for what they were able to do. Now, thankfully, at no point through the pandemic have I ever not been able to transplant anybody, nor have we not been able to give someone the appropriate intensive chemotherapy that they needed because of any concern about ITU beds. Now, that was pretty much through the goodness of the folks down here, despite the fact when things were truly at their peak, we still had a couple of punters that needed intensive care support, and very kindly created a safe environment to be able to manage those patients. But it really, really drummed home to me that we cannot do what we do without you guys, not just in the context of the potential for the mess that can come up, but also for supporting those patients whenever they really do need it. So that did, across the UK, change how we manage some of our patients. Those that didn't do so well were myeloma patients, so all those planned autografts of normal intensification to high-dose therapy have been backlogged. We're playing catch-up with them. We decided that if someone was going to be dead within 6 to 8 weeks without an allogeneic bone marrow transplant, that went ahead. Anything beyond that was kept on the back burner. And again, anything that was being done with curative intent, which predominantly were your Hodgkin's disease patients who needed consolidated with an autologous transplant or high-grade lymphomas, they were the ones that we prioritised. anything else that was further down the pecking order has been left behind. It has left us with a pretty significant, huge backlog, and actually nationally a lot of the transplant centres across the country were having to mix and match a bit to help each other out. Guidelines came out for us through, similar to yourselves, we had the multiple disease groups that we had to look after. So we had patients with high-grade lymphomas, we had patients with low-grade lymphomas, we had patients with aplastic anemia, we had patients with acute myeloid leukemia, and every expert group in the country was producing their own individual guidance at the time about how these folks should be managed. Positives that have come out of that, we've been able to use treatments that up until COVID weren't funded, that are more deliverable on an outpatient basis and have given similar remission rates in the world of acute myeloid leukemia and have got people to curative transplant. The good things about it. Bad things about it are there were a lot of people with low-grade diseases where their maintenance chemotherapies were put on hold. They've subsequently relapsed with high-grade disease. We found a lot of high-grade lymphomas in particular in a complete mess. They were coming in with multi-organ failure and rampant burden of lymphoma disease because they were either scared to come to hospital or couldn't get in touch with the GPs or just couldn't get through the hospital environment. So it was a bit of a double-edged sword from that perspective. Patient groups and patient forums in the world of haematology, they've always historically been pretty vociferous, but they became even more vociferous during the world of the pandemic, and were very rightly, independently, proactively trying to get their disease taken forward in a way that it wouldn't be left behind or it wouldn't be not treated as such. But all of us across the country in the world of haematology had to make pretty conscious decisions about those that we would treat and those that we wouldn't treat. And initially we were doing it ourselves, but then like yourselves, it came out in guidance through national groups. So it's been a tricky time from that perspective. Again, an example of that would be aplastic anemia. We used to give patients intensive therapy with ATG. They were in hospital for about 6 weeks, often could have ended up in intensive care, and now we've just been using oral immunosuppression and ultrathrombopine, which is a platelet bone marrow stimulator, and those patients have actually done quite well. So it was the pros and cons of how we manage patients through the pandemic. I think historically, certainly when I was growing up in the world of being a medical student, you were pretty lucky if you had a hematological disease and managed to get into intensive care. It was that 70s, 80s kind of feeling that if you had hematological disease and you ended up in intensive care, that nobody made it out, and to some degree that was probably true back in the day. You then get our version of things whereby we will always be patient advocate and try and explain to them all, it'll be fine, we'll get them in, all we need to do is support their organs for a week, 5 days, and we'll turn it around. And we all know that that's not necessarily the case. But historically there was a certain group of probably elder statesmen, intensivists across the country that have taken quite a bit of persuasion over the last 20 years or so that actually hematological outcomes have changed. They're much more positive, and that these patients can get through intensive therapies and organ failure as a consequence either of their disease presentation or if we've made them ill because of what we've been doing to try to fix them. Guidance-wise in the UK, there was a group that was back in the day in 2015 that looked at the available evidence, and essentially the final outcome of that was that in anyone that was deemed appropriate, there should be a trial of ICU. But I think certainly locally and historically here, like Anne Hunter over the years, I'm sure Ian and Gareth and the team will recollect, was a very strong advocate of haematology patients, and certainly when Anne first arrived, there was that feeling that there was not a block, but less of a persuasion to perhaps get patients with hematological conditions into ITU, but certainly that's something that's changed over the years. And since I've come to Leicester in 2003, there has never been an issue, I've never had any major issues with regards to getting patients accepted. And I think that's been because of the communication that we have between both departments. It's not through any magic formula or drastically different outcomes than elsewhere in the country, but I think it is purely down to communication and picking and choosing the right folks, and the belief that both ITU and ourselves have that we don't needlessly bring people in and we try and get the right folks to the right place at the right time. Sorry. Haematological admissions in ICU, this is preaching to the converted, but roughly a couple of % of all ICU admissions in the UK. About roughly 7% of our patients will need some form of organ support at some point through the treatment journey. Transplant population, it can be as much as 13%. Common culprits, sepsis, respiratory compromise, interstitial pneumonitis, and then potentially bone marrow failure complications cause bleeding issues. AKIs, for whatever the origin of that might be, it might be chemo-induced, it might be tumor lysis or metabolic disturbance, and those are usually in ranked order the reasons that people come down to. I suppose before COVID kicked off, our classic example of a COVID pneumonitis patient would have been those patients that we've allografted that had a viral pneumonitis and they essentially behaved the exact same way that you would find out that COVID patients behave, although the outcome for COVID patients in ITU is still significantly better than the outcome of hematological disease in ITU. I'll touch on that later on because there are also national data about how hematology patients have fared through the pandemic. This was work I think that Neil and Jenny Briggs historically had looked at over time, and I think John Parker as well. And if you knocked it down to numbers, the majority were acute leukemias that were coming in at some point through the treatment. The majority of the rest were lymphomas and sometimes myelomas. Most of the myelomas would be patients that have gone through high-dose therapy rather than those that have gone through induction treatment. But you've had the odd patient of all of the above, the other disorders that we look after. In the transplant program, we worked out that roughly about 35% of ITU admissions were patients who were going through bone marrow transplant, either autologous or allogeneic. This is just to give you a bit of a feel for the way that transplantation has expanded worldwide. This is CIBMTR, which is American data, but it pretty much mirrors what we do in the UK as well. The original sort of peak in the autologous, which is the top bit of the graph in the late 90s, that's when solid tumours, the on vogue was to give them high-dose therapy, but it worked out that breast tumours and other solid tumours didn't necessarily respond to that, so things levelled off. But you can see that there's still a pretty steep upward trend in the volume of autografting that we do, and allogeneic transplantation has just been a persistent upward trend from when we started to be reasonably good at it and safer at it, and that's the way things are still going. In the UK, at any one time, you've probably got about 2,000 or 3,000 patients that potentially need either an allogeneic or an autologous transplant for whatever disease that they've got. And again, that translates into nationally the amount of transplants that are done. In Leicester, we do about anything from 70 to 90 a year, and that tends to be a mix of autologous, probably about 40, 50, and the rest will be allogeneic. In the allogeneic cohort, the majority are unrelated donors. About another 15-20% will be matched related sibling donors, and then the odd cord unit we've thrown in. We're also about to start up a haploidentical transplant program, and we've got the first haplo-patient transplant coming up in the next few weeks, because that is a process now that's far, far safer to do than it was 5-10 years ago. We don't expect any increased mortality or morbidity to impact on you guys with that program. It will just be the same as an ordinary allograft patient for all intents and purposes. What's the difference between an autograft and an allograft? Well, basically, an autologous transplant, we're using stem cells from that person. We will get those stem cells usually by giving them chemotherapy plus or minus growth factor. Through COVID, we've tried not to give them any chemotherapy at all, so we've just been giving them GCSF and another drug called TRICC, which basically releases the glue. It's a CXCX4 inhibitor that keeps stem cells glued together in their microenvironment in the bone marrow. But in a nutshell, an autologous transplant, we've basically just given somebody a sledgehammer dose of chemo and it knocks out whatever residual disease is left there. Now that can be curative for diseases such as Hodgkin's disease that have not responded as we would have wished to frontline therapy or salvage immunotherapy. or it could be to cure high-grade lymphoma that has come back second time around or was primarily refractory to treatment. And then the other big cohort of that patient group that have autologous transplants, although it's not curative, it's disease control, your myeloma patients. And that will die down about 3 to 5 years, whereby they don't need systemic chemotherapy. Allogeneic transplant then is a different ballgame. That's where you're literally replacing the recipient's bone marrow with that of their donor. And the rationale there is that these are patients who will invariably, in the majority, succumb to their original hematological disease if they don't have a bone marrow transplant. Two ways of doing that: you can give them full-blown myeloablative therapy or a reduced intensity protocol, which I'll talk about in a little bit more detail as well. The mortality and morbidity ballpark figure for anybody going through an autograft is about 2 to 5%. Nationally, we are running about 1.2, 1.3%. We have been 0% up until the last 2 years. We've had 1 death in 2 years from our autograft population, which was actually fairly recently, but that's progression of disease in myeloma. And I think, again, that's testament to the input that we've had from the ITU team here in the Royal, because a significant number of those autografts have come through ITU and have survived to home and survived to day plus 30 and survived to day plus 100 and have actually survived to day plus 1 year. Allogeneic morbidity mortality is roughly around about 10 to 15%, but a reduced intensity transplant ballpark figure is probably more like 5 to 10%.
Well, nice questions, but
yeah,
probably going to display a total lack of understanding. I've never been into an autologous for taking a patient's stem cells who's got an acute leukemic process, a cancer process.
Yeah, so we've only used an autologous transplant. We've tried looking at autologous transplantation in the world of acute myeloid leukemia, and the problem was that there were dormant leukemic stem cells in the bone marrow environment. So for that disease, you wouldn't use it.
Right.
For something such as Hodgkin's disease, you're not usually going to have marrow involvement, and you would have cleared the bone marrow by the time you got them to that point. And likewise for high-grade lymphoma, again, their bone marrow should be cleared before you've done that. Myeloma patients can have residual stem cell or myeloma cells in their bone marrow, but there's been lots of studies done when you put them through induction treatment and whether or not there are myeloma cells in the bone marrow or not. You can actually purge the product. You can actually give chemo to that autologous product and put it back into them. And likewise, we fiddled about with giving chemo over the years to stem cell products for allogeneic donors to see if that made a difference, or antibody therapy, T cell depletion of the product itself to try and reduce stem cell or GVHD problems. But in a nutshell, autologous transplantation, you're not that bothered if there is disease in the product. I know that sounds a bit weird, but you can get away with it.
Presumably rejection is never a problem with autologous.
You know, you can get rejection with autologous, but that would be either you've not got enough of number of stem cells. So we've got a baseline figure of 4 times 10 to the 6 per kilogram is what we request whenever we harvest that patient of stem cells, or CD34 positive stem cells. But I've given up to 1.0 would be my absolute baseline, and you can still get engraftment, but that engraftment might be sluggish, so you get a platelet count that will be stuck in 20s or 30s maybe for 2-3 months, a white count that will just creep up over 2-3 months, but you can still get away with it. But 2.0 times 10 to the 6 is the magic number with regards to what allows your bone marrow to work. And likewise, in an allogeneic population, it's 4 times 10 to the 6 of nucleate, or 4 times 10 to the 6 of CD34 cells, but 4 times 10 to the 8 of nucleated cells, which includes your cord units and unrelated product as well.
Thanks.
So a myeloablative transplant is where you literally frazzle them, so you either give the maximal dose of total body irradiation plus or minus maximal dose of chemotherapy, and the two can often be put together. You're talking about anything from 12 to 14 Gray, which is what our young lad has had next door at the minute. So he had full-blown TBI radiotherapy and high-dose chemotherapy to eradicate his leukemic clone, but despite the fact that he was in remission, would invariably have definitely come back. Back in the day in the 70s and the 80s, when they were starting this out in centres in London and elsewhere, Nottingham, across the country, they basically just had patients with refractory disease and they frazzled them. So there was no actual effect on outcome there because they killed 80 to 90% of everybody that were transplanted, but about 10% or so of those patients who were primary refractory or hadn't responded to anything else actually survived, and that is why we still allogeneic transplant patients today, because you can sift out those that actually will win and will get through and do well from a bone marrow transplant. Over the 90s, we realised that to reduce that high treatment-related mortality that literally was 60 to 70% in that original cohort during the 70s and 80s, if you reduce the intensity of what you gave their bodies, so literally you're just giving them chemo to make a space in their bone marrow environment for new stem cells to thrive, but you also need to knock out their immune system, and that's where so-called reduced intensity transplant comes in. So you're just making a physical space in the bone marrow environment, but knocking out that recipient's immune system, usually with antibody therapy with Campath or ATG to get rid of the B cells and T cells, and then that slowly allows the immune system that comes along with the stem cell transplant to actually take hold in that patient. And we can measure that in a thing called chimerism, which just gives a signature of the immune system of both the donor and the recipient, and the aim is to get them towards 100%. You'll hear us sometimes talking about DLI, or lymphocytes being infused, and again, that's just using the lymphocytes to prop up the immune system, because if you get it to 100% of the donor, the rationale is that you will develop a graft versus tumour effect, and you've specifically trained T cells that are now in the recipient that originally came from the donor to actually attack whatever residual leukemic or lymphomatous process might be lying around. And that's pretty much what we do today. We really try and be patient and disease specific about whether we myeloablate or whether we offer them a reduced intensity transplant, and that allows me to consider maybe someone who's got AML, high risk, first remission, who might be over the age of 70, but if I give them the minimal amount of preparation, toxicity, and still get a stem cell system in there, there is that chance that that patient will survive and make it through to another 5 or 10 years of life, or otherwise it will be good. Haematology, we're big into our clinical trials. I have to admit, COVID's completely screwed the situation up totally. We really struggled to recruit in the last 12 months locally. I think a lot of that has been around, everything is very much dedicated towards the COVID surge and COVID side of things, but we have also still managed to recruit to national leukemic trials and national transplant trials and our phase 1 unit in particular in lymphoma land here, but it has been a tricky time trying to get that sorted out. Making people survive longer from a bone marrow transplant in particular is a multidisciplinary approach. It's not just about one thing, there's multiple things go on in the background. We are fairly strictly regulated, so I have to get accredited through a group called JC, which is a European and national, actually, or international group that accredit us, inspect us every 2 to 4 years and make sure that we are fit for purpose. And we are also benchmarked now, not just nationally, but internationally. So every patient who comes through the transplant program, every quarter I have to produce a report to the local commissioners, to the specialist commissioners nationally, and also to the European group of transplantation as well. So we're really under the microscope a lot. We're doing about 70 to 90 transplants a year, and you've got a little brisk bit of morbidity or mortality. It can make numbers look pretty grim sometimes. So it is why you might think I seem a little bit invested, well, you know, in the whole process of everything we do in these patients, and why we really need to try and get them out the other end as well. It's a little bit, it's just like when surgeons or yourselves look at your outcomes of, you know, your 30-day mortality and everything else. But the quality management system that's behind all this actually drives better outcomes. It's not just there to show, it's genuinely, we've got a live and breathe quality management system that means that every process from stem cell collection to that patient having a transplant to the follow-up and late effects and the way that they're managed, even in your environment, is done in a way that is built to make the outcome more positive if we can't get away with it. Mortality-wise, if you were a haematology patient into ITU, this was pre-COVID, probably globally there was about 50–55%. Survival is definitely better in higher volume centres, of which you guys across all 3 sites would have historically counted as. I think in particular here in the context of the transplant programme, I've developed a fairly close relationship with everybody down in ITU here that makes a difference in outcome. And likewise in Glenfield, we'll visit patients, or a lot of lymphoma patients will come through Glenfield and ECMO in particular, and there's been a few studies and case reports and various research papers have been written about that as well. They're not particularly special hematology patients in that there should be similar outcomes for those that have similar Apache or SOFA scores to medical patients that come in a bit of a mess as well. There is a definite difference though in outcomes for those who electively come into ICU for X, Y, or Z, or for those that are just post-surgical. The only thing that we tend to do here in Leicester is if I've got messy acute leukemic or a messy high-grade lymphoma patient, I will electively try and get them admitted down here sometimes and get you guys to keep an eye on them, make sure that they don't run into problems with AKI because the tumour lysis to need filtered, or any metabolic indication at that point to need filtered. And we do have a bit of in-house data to show that those patients have done better than they otherwise would have done compared to historic controls and cohorts. I think this was Neil, John and Jenny predominantly, and apologies if it was other people who've been involved with all this, but this was local data through LRI ITU unit. And there was roughly about 78 we worked out over a certain time frame that come through the place. 56% of those managed to get discharged. 37% of that cohort population did manage hospital discharge, and over 95% were still alive at day 30. So it's not that these patients are going through and then crumbling and not making it out the other end. There is a bit of evidence that they actually do make it out the other end properly. What does change the ball game, and no surprise to you guys, is the amount of organ support that they need and the amount of systems that go tee up really makes a difference. Self-explanatory, the figures there, but basically if they're just coming in for NIV or, and worse, unsupported or just ventilatory support with not much else going on apart from a bit of inotrope, then they were generally 22% survived discharge. If, however, you threw in renal with respiratory support, 14% were going out, and unfortunately what still is pretty grim, and we all know is usually the outcome, is when everything goes the wrong direction of that cohort, we couldn't think of anybody that comes through otherwise. Historically, there are 1 or 2 patients who we know were on everything that are out the other end, and one of which does give you guys a check for £1,000 every year, still to this day, I do think, I believe. So it can be done, but they are the exception. And we're back to the point of all systems needing support, it's usually bad news. Again, from our perspective, we tend to be proactive about that. We won't just sit back and put our patients down here and not appear again. We tend to be around once or twice a day. We'll always be in contact with the on-call team that are on the floor for intensive care throughout that period. And we'd usually be involved in any major decisions about where we go to or where we stop. And we also like to think we're fairly sensible about stopping as well, and not getting into a situation that we feel is beyond where we should have got to in the first instance. If you look at the literature, I think it is out there now. There's enough abstracts out in multiple intensive care conferences, hematological conferences, that trial of ICU that's indicated is reasonable. 4 to 5 days is probably what we would advocate from our side of things. I think the validated scores that are out there probably are not necessarily completely across the board the way that they should be for hematology patients, because they are slightly different. I think what's becoming clear through COVID is that there was a definite signal of excess mortality in hematology patients in ITU with COVID. In particular, the myeloma patients had probably the highest mortality, which is no great surprise. A lot of them had secondary antibody deficiency, were in their 60s, 70s, 80s usually. Other patients that had conditions such as CML, there was no particular signal. I think there was only 1 or 2 CML patients across the country and actually succumbed to COVID. Allogeneic patients, this is sort of personal communication data I've got from the European group. There's about 20 to 35% mortality in allograft patients who had COVID and were admitted to ICU. And for autograft patients, again, it was 10 to 20%, and that is against probably, that's about an odds ratio of 2 to 3 times the mortality that we would have expected for those patients normally coming through. So COVID has definitely made an impact and a difference from those patients. I think post-pandemic, we do need to relook at criteria to admit haematology patients to ICU for various reasons. Time-wise, I'm just worried about that. What time is it? Because I did start late. Just to give you a bit of an idea for where haematology is at the minute and where we've got to and how we got there. So chronic myeloid leukemia, back in the 60s, most patients would have died. All that was available was splenic radiotherapy. And even up until 10 years ago, the only true cure or management of CML would have been an allogeneic bone marrow transplant. But with tyrosine kinase inhibition, that has changed. These patients basically have a normal life expectancy now. And the reason it's important, it was actually, CML was the first ever cancer that was worked on at a molecular level, and the 922 translocation switches on an oncogene that pretty much keeps the tyrosine kinase stuck in the on position and just keeps this stem cell self-renewing. And it's really just the perfect example of working out at a molecular level what makes a cancer or hematological cancer tick. If you can block off that, and in this case it's just one molecular driver, so you really can fix and cure these patients. Childhood ALL, back in the 60s it was universally fatal. Nowadays, any kid with ALL, you will expect to be alive in 20, 30 years time, 90% of that population. APML is now, I would expect to cure everybody with APML that comes through the doors. Biggest thing that still kills promyelocytic leukemic patients is gross thrombosis or bleeding at the time that they present with their disease. But when they get through that first few weeks of treatment, we would expect to cure all those patients. We can actually do that nowadays without chemotherapy. We actually give them arsenic and atra, which are all just differentiation agents, and can also monitor their MRD level through bone marrow testing sequentially every 3 months, and actually pick out one cell in every 6 or 10 million that might be an APML or PML-RARA leukemic clone, and give them extra therapy or reduce their therapy based on that, and that's how those patients are now cured, which is amazing because then it means they're not up against the late effects of chemotherapy and everything else. 80% of people will survive Hodgkin's lymphoma, and when I say survive, that is greater than 10 or 15 years survival. 67% of high-grade lymphomas will make it through. Myeloma, when I was coming through the ranks, 1 to 2 years was your median survival. Now it's actually getting up to median survival of 10 years in all myeloma patients that we look after, and there's about 10 or 11, 12 drugs been approved in the last few years. And that again is just to prove to you that people actually are living longer and surviving longer from the understanding of the disease mechanism and molecular understanding. We're autografting patients who are older. I think that's important for you guys because it means if I do more 70-year-olds, then there is a high chance those patients could enter into the world from the intensive care environment. We do need to be careful about those. We do pick and choose those patients very carefully ourselves, but there's a 5% morbidity mortality for those folks ending up in ITU. But again, that just shows you the top bit, which is the orange bit, that we're a bit more generous, and it's not that if you've just reached the age of 65, you're told that's it, we can do nothing for you anymore. Again, this just gives you an overview of the kind of diseases that we treat. The majority of transplantation still relates around myeloma, autologous transplant, plasma cell disorders, Hodgkin's disease, autologous, and AML is the predominant allogeneic population that we would allograft, and sometimes ALL patients as well. This is just to show you why hematology is a little bit complicated, and AML in particular. So this shows you the molecular drivers behind acute myeloid leukemia. So it's not just one disease entity that you're trying to sort out. So it's why one glove does not fit all, and just giving someone ordinary good old-fashioned systemic chemotherapy. This is why people sometimes don't remit, or people do remit. And there are multiple molecular drivers and other cytogenetic issues that can decide if that patient is in remission or not. We now have a lot of individual drugs for these individual molecular drivers, and we will, every patient we take through now with acute myeloid leukemia, we will do next generation sequencing on those patients. So we're getting a sort of map of 20 to 30 genes that may or may not have potentially small molecules available to be able to treat them. The problem is not all these are licensed at the minute, and it can be really difficult when you've got relapse patients who will literally go into remission with a single drug, and we've got 2 in the go at the minute that we're about to allograft. We've been rescued from primary refractory disease because we've worked out which driver mutation they had, and we've been able to individually just give them an oral drug that has got the disease into remission, not chemotherapy. This is pure molecular sort of science. The other thing that I'm a bit worried about, we are through commission and nationally supposed to whole genome sequence a certain number of patients with AML, which is interesting but madness, because we're expected to consent them as well. We've done our 3R, whatever it was, online tutorials to be able to consent someone for whole genome sequencing. But I think if I walk through the doors with AML, the last thing I want to know is when I'm going to die from the Alzheimer's if I actually survive my AML, and what the implications are going to be for the rest of the family as well. And that is literally now what we are expected to do in some of these patients. And what do you do with information? Because you've literally, your WGS and their whole genome, you're going to find a whole shitload, excuse my French, of other things that are going to be there. And I personally feel uncomfortable about doing it. I haven't done it yet myself, and I think we've all buried our heads in the sand a bit with this in haematology. Not actually consented anybody yet, but there is this national drive that this is what we want done, and it's
What's the driver for that?
the drive is the Sanger Institute, and people writing papers and government money that's been put into it already. That's a bit unfair. It's not necessary. That's not the reason. It is to understand the disease, and it would understand the disease in a more complex environment, but at the same time, you can't take away from the baggage that you're going to identify with those patients. Plus, what you really need is someone like Gillian Barwell consenting those patients or discussing the outcomes of what you're going to find in that sequencing. Because I'm not going to be able to talk to someone about what the kid's risk is of Huntington's or whatever else if you do find something like that, and that's literally what we're talking about. But yes, it would be great to whole genome sequence every patient with AML or ALL 100% and get it, but the information I want from that is not necessarily the information that that patient is going to have to deal with in a more complex environment. So that is a bit of a tricky situation, but it is where the world of certainly haematology and oncology is probably headed the next 5-10 years. Everything is going to be driven by sort of genetic sequencing of that individual's disease with the amount of small molecules that are out there, the amount of immunotherapy that's out there, bispecific antibodies, etc., etc. It is really turned into smart medicine now in the way that we try and cure patients with leukemia and or oncological disease. That was a moment of, it was too late at night, shouldn't have done that. It could have been worse. Just really briefly, this is just, you've got a patient coming through the unit at the minute who's in the throes of horrible, horrific grade 4 mucositis. Basically, TBI, the drugs completely clear out your mucosa, cleared out B cells, cleared out T cells. These patients are absolutely sitting duck for translocation of organisms into the bloodstream and causing sepsis. I've not talked about the gut microenvironment because it's literally a talk in its own right, but increasingly there is research and real life data that shows what antibiotics we give our patients pre-transplant, pre-induction chemotherapy has an outcome on their survival. And basically it's good bugs versus bad bugs in the microenvironment, and there is actually a GBH signature in gut microflora that you can pick up in genetic sequencing that shows those that survive versus those that don't survive based on which class of antibiotics they've had pre and post transplantation. It is probably the next big thing in the world of transplantation and leukemia is managing the gut environment. And again, it's where your C. diff fecal transplant comes from and everything else, that kind of stuff. But that's probably where we're headed. In Europe, there are a lot of transplant centres that routinely fecal transplant their allogeneic patients routinely to reset the gut biome in the post-transplant phase, so that you don't end up with a VRE, you don't end up with standard Enterococcus faecium sepsis or whatever because of that translocation. So it's basically good bugs versus bad bugs. So that's probably the next big thing in the world of transplant. Patients are still dying from viruses. You know yourselves, our hit rate with viral pneumonitis is never good. COVID, even worse in the context when it's thrown into transplant patients. And likewise, fungal disease is still a big killer in our patients when they get to the world, or when they actually make it to ITU. Autologous transplantation, the key take-home message about this is most patients will succumb to their disease if they die, and that's where the big bit of blue is in that pie chart. Few of them will die from infection or otherwise. Whereas, if you get to the world of allogeneic transplant, most patients will actually survive their disease and not relapse from their disease, but there's other infective complications and everything else that become more problematic, but also longer term complications can kick in and kill those patients as well. Time is pressing. So I think, just to summarise from my perspective, I think it's picking the right patient to come into intensive care, not missing the patients that should have intensive care. Cannot highlight the communication enough, between ourselves and intensive care. I think that really does make a difference for outcomes, not even necessarily good outcomes, but in the way that we manage patients, their families, their expectations in the context of how we work with ITU. The mess that they might be in at the start is not necessarily how they're going to end up, and I think that's always something you need to be aware of. When high-grade lymphoma comes in a multi-organ failure, that will still potentially cure the disease. That was just kilograms worth of lymphoma that's making that patient ill. When that melts away and hopefully there's organ reserve, that patient should and could survive their mischief. I think overall we agree that when you get through the doors, there's still significant morbidity mortality that we potentially could improve upon. And certainly I personally, we do speak to all our leukemics, all our allogeneic, all our autograft patients up front about if they're going to go through the process, that they need to be prepared to go through the process of an ITU environment as well. Otherwise I would struggle to take them through a transplant. It wouldn't be a deal breaker as such, because you could still transplant them, but at the same time they're aware of that before they come to you. There's not much out there in the context of randomised or approved trial studies, and basically there was no change in morbidity or mortality, whether a full-blown escalation or mid-escalation or length of time was made. Pretty much the outcomes were still the same. I think most of us agree if we're not going in after 5 days, we probably need to take a step back and decide what's going on and where we're at with it. I think locally things have made a difference. Starting the management of sepsis and the trust, the sort of interaction now the DART team does, even on a remote basis, that is definitely making a big impact, I think, in our patients. Very quickly, just new stuff that's on the horizon. This was all the basics of what we used to do in Heme-Onc, which was surgery, chemotherapy, radiotherapy, targeted therapies, which we talked a bit about. Monoclonal antibodies were the next big thing. They made a huge big difference in the world of lymphoma, but also how we look over T-cell deplete patients in transplant. We then moved on to sort of bispecific antibody therapies and chemotherapy. So these are drugs that latch onto the surface of the cancer cell and release their inherent chemo directly into that through surface markers on the surface of the cell, or have used a T-cell to get to that point. The next big thing, though, was immunotherapy and getting T-cells to literally gobble up tumour cells, and that is what's happening in an allogeneic bone marrow transplant with the graft versus tumour effect. That also is what happens when patients have immunotherapies, whether it's for solid cancer disease, Hodgkin's disease, or CAR T therapy. That is literally what we've done. All immunotherapies do is they turn cancer into something that those drugs and the T cells in the body can actually look at and recognise and latch onto and eat up. And it's sort of a little bit the way that T cell management in the world of COVID has gone to try and switch off inflammatory and cytokine responses as well through the drugs that you've used. This slide was actually old, but I think it's important because with all the work that's been done in vaccine therapy, I cannot see that there will not be vaccines available in the same way that they've ramped up COVID vaccination to actually target antigens in the surface of cancer cells and hematological cells. Now, this was old work in heme and it's sort of gone by the wayside, but with the messenger RNA side of things now, I think it's going to be a whole new thing and it's going to open up and potentially offer more therapy. CARs, I'm just going to talk about really, really briefly, but basically CAR T cells nationally are now commissioned in the UK for high-grade lymphoma patients who've got refractory disease in adults. But they've also now just been commissioned for mantle cell lymphoma in adult patients, which is a bit of a political one rather than a real life one. And also ALL in kids who are refractory, and those kids literally can survive now long term with CAR T treatment, where otherwise they would have died. Unfortunately, if you're over the age of 24, 25 with ALL, you're not actually eligible for that potential therapy now when our trials open. And basically what CARs do is that we extract T cells from the patient themselves, those that are reprogrammed through viral vectors to actually recognize a spike protein, for want of a better word, on the surface of that tumour cell. We then expand those in vitro and manufacture them in industrial numbers, and then we reinfuse them back into the patient, and the reinfusion needs the patient to be prepared in the same way that an allogeneic bone marrow transplant patient is prepared. So we basically have reduced intensity like conditioning, and then the cells are put back in. They eventually expand and hopefully gobble up the T cell or the disease that they're trying to kill off. Just a little bit of proof that they do work. There was up to 40 to 70% survival in some of the patients that went through this, but as you guys will know, there was a big issue with CRS and neurological toxicity. Tends to occur about 5 days afterwards. All the classic things that we now know so much more about in the last 12 months will go up, and you can end up with a syndrome that does respond in the same way to TOSI or anakinra that you've already found out works in patients sometimes who are in a bit of a mess with a macrophage activation syndrome with the COVID, or T cell cytokine response with COVID as well. Bad things that they do, they knock out your B cells, and some of them still need allografted or regular immunoglobulin replacement afterwards. They can also get horrible CNS toxicity, and you do need a really on-hand neurology department and access to 24/7 EEGs in the intensive care environment. The CRS is pretty extreme, and patients can end up with a multi-organ failure, but the big thing here is over 90% of those will survive that. They actually get out the doors in one piece, even if everything had to be supported through that, whether they needed TOSI or steroids or not. And that sort of gives you a view of the kind of cytokine storm that you probably see with COVID patients as well, and TOSI being thrown in and what they're like 24, 48 hours later, they've just completely switched off their cytokine mess. And that, those bright bits are a PET scan on the left, that's all horrible big lumps of lymphoma, and the bits on the right are what happens after you give someone CAR T cells and they engraft and they actually work. It melts disease that otherwise people would have died from. The reason I put that up is nationally there is still, Birmingham's commissioned, but there will probably be a likelihood of either ourselves or Malignant getting a commission, but that is for greater powers than me to decide in a minute. And we had talked to Neil and Gareth historically about what that might mean for the service here. I think that says a lot that in the next 5-10 years, and I've already had this conversation historically over time with Ian, Gareth, Neil and the team, that we probably feel there's a 5% increase coming your way from us There's probably actually more, I suspect, because of what's happened with the pandemic, and also a lot of the drugs that come out of the pandemic are drugs that we've sort of used in the world of haematology, but I think we really know how to use them now in a way that's much more sensible through a lot of the trials that come through. So I'm sorry, that was a bit of a mishmash. It was not, I didn't want to talk about COVID today. I was going to talk about COVID and haematology, and I thought, nah, I'm probably sick of COVID. The only thing I will mention is VIT, so the vaccine-induced thrombocytopenia and clotting that we're seeing. It is pretty catastrophic. It does need really high D-dimers in the presence of a very low platelet count. And for whatever reason, something in the AZ or the Johnson & Johnson is stimulating a reaction of PF4 and immunoglobulin complexes. PF4 is just a platelet activating thing that floats around your plasma normally. But these immune complexes will then cause the platelets to activate, get used up, get dumped, and then you're just completely prothrombotic. And the way to manage it, as you now know, is it's immunoglobulin, it's steroids, and there's even another dose of immunoglobulin if the platelet count hasn't gone down. But we've had a couple of really dire cases in that you guys have been involved with as well, where they just clotted and clotted and clotted, despite being on anticoagulation with whatever it was at the time, I don't know if it was DOACs that were used or Gatraban or whatever, but we're also realising that they'll probably need anticoagulation for at least 3 months. It might be 6 months that they need anticoagulated for, and they obviously need to avoid heparin, but these are not pre-sensitised events. Did look at a paper last night, it's just hot off the press. There's talk about even things such as EDTA that were in the recipe mix of AstraZeneca might be one of the things that they think is stimulating the immune complex response. There's a couple of other standard vaccine ingredients as such that they think might have done the job, but it is a bit of an issue. There's a definite signal there it exists, but as we say to all our patients as well, you're more likely to get caught if you smoke on the pill or whatever else, so less likely than if the AZ vaccine.
There's no case report of non-AZ.
There are a few case reports in some of the RNA ones, but it's not as immunogenic. So whatever is stimulating the immunoglobulin complex reaction with some specific ingredient in the AZ and J&J, that different version of vaccine. But it's really catastrophic clotting that they're getting. There's been 3 MIs over at Glenfield, there's lots of arterial through the vascular surgeons as well. Yeah. Lots of weird and wonderful stuff coming through, and it's just, it needs to be managed completely differently. I'd urge, if you just Google BCSH guidelines, there is up-to-date, week by week advice, and I'm sure you guys probably get through your ITU and ED pathways as well. There seems to be things. So that's the only thing I would say in the world of COVID at the minute. I'm sure you're all glad to be less COVID-y at the minute. But yeah, the take-home message is we cannot do what we do. We can't treat hematology patients without intensive care involvement. I think we're pretty blessed in Leicester of the relationship that we have between both departments, and it really does make a difference. And again, when you talk to patients, they're incredibly complimentary to you guys when they've come out the other end as well, and it makes a huge big difference for us. And I literally couldn't transplant. I had to stop the transplant program when you guys were around. I can't do what I do without you, is what I'm saying.
Thank you.
So, like, happy if there's any major questions, and sorry for rambling a bit, but it was to try and get a general feel across rather than blind you with science.
That's brilliant. Thanks, Murray. So, has anyone got any questions? No one's got their hand up at the minute. Andy, do you want to ask? Got one question here from us guys at Glenfield.
I was going to ask, if you give these people high dose radiotherapy, is there a lot of secondary malignancy that will come from that?
So about 10 to 15% of patients who have total body irradiation will develop a secondary malignancy after 10 years. So that's why we never have them off the books. They're in constant late effects review. We encourage that they go through whatever national screening programs are out there for all the things that can be screened for, but their risk is basically anything tends to be solid tumours more often than not, but also secondary melodysplasia paradoxically. So MDS in the bone marrow environment as well can be more frequent, but ballpark figure is about 10 to 15% after 10 years.
Right. Thank you. Any other questions?
Just talking about the increase in the transplant rate, just about the transplant program.
Yeah.
We have access to intensive care, push the envelope of what you do, or are we still just a reactive? Which is interesting the way we deal with high risk surgery.
Yeah.
We plan, as you alluded to, we don't usually plan your admissions, but in high risk planned surgery, we have people booked in, treat them as planned admissions. Is that something moving forward that?
I think so. So there's some centres in the UK that have a blanket ban on allograft in anybody over the age of 70. They literally, it doesn't matter how good a performance score they have, what the physiology is like, it's not done. They literally don't do it. And I think the reason they don't do it is if you actually look at your data, it's crap. The survival is bad over the age of 70 from allogeneic transplant, but the reason it's bad is from GVHD. So sniff a steroid, they'll end up with infections and they'll die. Their disease is usually in remission, so the actual graft versus tumour effect has worked, but they die from infections or immune complications. But because we're getting more savvy and we're actually really working now in the microenvironment of the HLA system, we're getting to the point where you're going to soon be able to probably generate a GV leukemia lymphoma effect predicted from your knowledge of the HLA minor histocompatibility bits involved. So you can literally pick and choose who's going to not get GVHD and stimulate a leukemic clone. The brighter and smarter we get, and that's the Nobel Prize. Whoever can do that will get a Nobel Prize because you will be able to stop graft versus host disease in its tracks and actually just have pure graft versus tumour effect. So, are we going to transplant more? Yes, we probably are, Gareth. Sorry. And yes, there are going to be more knocking down the doors, I suspect, as we predicted over the next 5 years.
Suddenly sticking a tube down and starting some more items to very clever.
Yeah, I think if you pick and choose this space, like, fair enough, if they've got transient reason why they're in an AKI that just need filtered for 48 hours or something, or they've got a trial of NIV, and fair enough, they don't. I think we all know if those patients need ventilated, then that's usually that. So I think we need to be savvy about them, but from a sepsis point of view, if it's just sepsis and they need a bit of inotropic support for a couple of days to get the tick through, then so be it. And I think we have to be very careful and pick and choose, and also not get you disheartened that you don't want to go near them if they're all dying. So it's not in my interests to transplant everybody over the age of 70, Dr. O'Leary.
We trust you.
Okay, I just wonder whether in the interest of time we just move on to the journal club bit of this. If that's okay. Thank you very, very much for that talk. It was really, really, really interesting. So next up we've got Eden's going to talk about the TRICC trial.
Hi, my name's Eden. I've met most of you now over the last couple of weeks, so I'm going to do a really quick whip through a classic trial before moving on to the more novel paper. So in the keeping of the haematological theme, I'm going to talk about transfusion and critical care. So specifically, this is euvolemic anemia. So we're not talking about bleeding patients, we're talking about the anemic patients that become anemic during their ICU stay. So the TRICC trial was published in NEJM in 1999 as a seminal paper. And one of the premises is that our patients often have multi-organ dysfunction. And obviously hemoglobin's key to oxygen delivery to tissues and organs. So therefore, if we optimize that and not tolerate anemia, perhaps our organ failures and patients would do better. On the flip side to that, transfusion is not without its risks, as transfusion reactions, as fluid overload. There's also the time that this was done, blood was managed a bit differently, and I'll come on to that a bit later. So potential reactions from the blood products itself. So it was a Canadian study, TRICC. It was 25 ICUs. They excluded, or they wanted to include patients that were going to be in ICU at least 24 hours, so not your bed and breakfast post-ops, with a hemoglobin of less than 9 within 72 hours of admission to their ICU, so not like 1 month into their stay, and euvolemic as per the treating clinicians. They've excluded a lot of people, including cardiac surgery, pregnancy, brain death, people who are not going to be escalated for obvious reasons. Anyone knows any concerns about active bleeding, or obviously contraindications to transfusions for other reasons. So they randomised. There was two groups. There was a restrictive arm whereby if you had a hemoglobin of less than 7, you would be transfused 1 unit at a time until your hemoglobin was more than 7, aiming for the 7 to 9 range. And a more liberal group where if your hemoglobin was less than 10, you'd be transfused no matter what it was. You'd still get 1 unit at a time and a hemoglobin check after each to make sure that you didn't sort of breach your protocol, aiming for a target of 10 to 12. The nice thing about this, they stratified it by disease severity, so with an equal proportion of really, really sick people versus sick people in both groups, and also by centre in case there's any other practices that are centre specific that might influence the outcome. So the primary outcome, fairly robust and probably something relevant to all patients that they'd care about, is all-cause mortality after 30 days of enrolment into the study. And secondary outcomes was all-cause mortality at 60 days, ICU mortality and hospital mortality. This was an equivalency trial, so they went in with the premise that restrictive transfusion is at least as good at, so otherwise more commonly known nowadays as a non-inferiority trial. And that's important for things like statistics and recruitment numbers, how many patients you need to be included into your trial. They estimated initially that 2,300 patients would be needed to be included. They then did some interim analyses and things changed throughout the duration of the trial. So this is what it shows. As you can see, they only included 838 patients, but they were you may or may not be able to read this, but take my word for it, they're very similar, the groups in both arms, and they represent what I think is a true ICU population, so at least one, but usually a couple of organ failures that are needing active support, so not your HDU type patients, but proper ICU patients. Now, I don't want to call it backward statistics, but if you're thinking about non-inferiority, if you see a significant difference between the groups, then it potentially isn't non-inferior. So the p-value that is not statistically significant does not mean it's a negative trial. So there isn't, remember, we're trying to say that there is not any difference, or it's just as good as to be restrictive. So the fact there isn't a significant difference would support that. But actually, if you look at the numbers, you'll see that the patients in the restrictive group actually seemingly seem to potentially have a better outcome than that in the liberal group. And that's held through all of the secondary outcomes as well. And if you're visual like me, you're like a Kaplan-Meier curve. And what this shows is that not only is the restrictive group as good, but perhaps it's even potentially better. There's a trend towards betterness with the restrictive strategy, but obviously it wasn't designed as a superiority trial, it was a non-inferiority trial, so you can't comment on that. And then you might think, but perhaps, if you're really, really sick, you would do better with blood transfusion, and maybe if we really select out those people, or maybe if you're old or young, it makes a difference. And that did not hold in the subgroup analyses. This is true uniformly throughout all of the ICU patients. So that's, I think, where most of our practice is at the moment. I think standard ICU transfusion threshold is 7 for most of us. But one of the questions that came out after this paper was published was, we standardly have a hemoglobin of 120 to 130. So why would anemia be protective? Is it in fact that transfusion is harmful? And one of the practices, again, about blood transfusion in those days is that blood was not leukodepleted, which means you're transfusing donor white cells as well, and that could cause an immunogenic reaction of some description. There was a small window of time where we could have done a leukodepleted versus non-leukodepleted transfusion study, but that was unfortunately never done. Well, I don't know, unfortunately, not unfortunately. I'm not sure, but that window opportunity has passed. So now all blood that we give is leukodepleted. that's what's available to us. So that's really the take home from the TRICC. The other big study is TRICC, which is a similar premise again in septic shock, done 15 years later, showed similarly that non-inferiority of restrictive transfusions threshold. And one thing I won't talk about today, but maybe another time we can talk about transfusions specific to cardiac surgery, because they were excluded from both those groups and they've got their own set of trials going on. Other trials have tried to look at other less like non-transfusion related ways to augment your hemoglobin. So those of you might be familiar with the Iron Man study, looking at giving iron. We'll hopefully talk about those at some point in the future. But TRICC was today's study, and another subgroup which is always leads to controversy is what we do in acute coronary syndromes, and whether or not that ischemic myocardium might benefit from, you know, they've got ACS, surely they benefit from a slightly better hemoglobin, and that's been a subject of debate for a long time, what our transfusion thresholds should be for them. So the novel paper is going to be Reality, which tries to address that.
I'm Andy, I'm one of the junior fellows. I'm going to be talking about the Reality trial. So it's quite a recent trial, and basically they asked the question of, again, whether a restrictive strategy was non-inferior to a liberal strategy with patients with MI and anemia. So we know that anemia is a powerful predictor of major adverse outcomes in patients with acute coronary syndrome, but there is conflicting evidence with regards to exactly which hemoglobin threshold to use when transfusing. There's quite a lot of big trials like TRICC and other studies that have used different thresholds, so we're kind of trying to address that. And also, as Eden said, many of these trials have looked at patients with GI bleeds or septic shock, for example, but they haven't really looked at patients with MI. And also part of the rationale is the potential adverse effects. So, for example, like fluid overload or sort of allergic type reactions to transfusion, and obviously there's a bit of a scarcity of supply and the cost of transfusing patients unnecessarily. So the methods that they used were, so the trial population was adults that had an acute MI with ischemic symptoms and raised biomarkers, and a HB of 70 to 100. So they could be enrolled at any time during their hospital admission, and that was in 26 centres in France and 9 in Spain. And they had some exclusion criteria, so including shock, if they had a recent PCI or cabbage or massive bleeding. So they were randomised in a 1-to-1 ratio for each group. And the restricted strategy, they ended up going for a threshold of 80 for hemoglobin, just to maximise sort of clinician adherence to the protocol. And then anyone in the liberal group would have a hemoglobin less than 100 and aiming for at least 110. So, as I said, the primary outcome measure was major adverse cardiovascular events, or MACE, at 30 days. So it's a composite outcome, including all of those things there. But they did analyse it in terms of the individual components of that outcome as well. They also looked at adverse events, so for example, AKI or severe allergic reaction, but it wasn't kind of statistically powered to see if they were significant or not. So, so again, this is a non-inferiority trial rather than a superiority trial. And they looked at relative risk between the two groups rather than absolute. So they needed at least 300 patients, and they needed a relative risk margin of 1.25, and that was based on clinical acceptability. So kind of because there is an established benefit of giving transfusions to patients that are anemic, they wanted to not sort of detract too much from that in the trial. So that was where the 1.25 came from, and why they didn't do a kind of a control of no transfusion versus transfusion. So this is the actual flow chart from the paper. So they got plenty of patients, 668, so much more than the necessary 300 for statistical power. And you can see most patients that were randomized were kind of included in the analysis. Some ended up having too much blood in the restricted group, but most adhered to the protocol. So the results, I'm not sort of expecting everything from this slide to be taken in, but again, both groups had similar baselines, so they were quite comparable really in terms of their baseline characteristics. And so this is kind of the cardiovascular profile of the patients. So about 2/3 had NSTEMI versus STEMI. Most of the patients had no or mild symptoms of heart failure based on the Killip classification, and only about 10 to 15% had active bleeding. So the hemoglobin levels again were similar as a baseline in both groups. So about 1/3 of patients in the restricted group were transfused at least 1 unit versus almost the entire liberal group having at least 1 unit transfusion, and most patients in the liberal group actually had 2. And the HP nadir was lower in the restricted group as expected. Also, about 80% of patients in both groups had coronary angiography, and about 2/3, I think, had myocardial revascularization in both groups. So in terms of the primary outcome, you can see that fewer patients in the restricted group versus the liberal group fulfilled the criterion. So that was met the magic 1.25, and that was also replicated in the post hoc analysis. So accounting for the site effects, because it was at about 30 different centres. And this is quite a convincing graph, just showing that the restricted group was better off than the liberal group effectively. Although it wasn't powered for superiority, you can see that there's quite a convincing trend towards it in this graph. And then this was the secondary outcome. So you can see that again, that was kind of reflected in the each outcome was kind of less in the liberal group and in the restrictive group than in the liberal group. And you can see that this may or may not be statistically significant, but in the restricted group there was slightly more adverse events, but again it wasn't really powered to look at that. So as I said, the restricted transfusion strategy was non-inferior to a liberal strategy, but that may have included clinically significant harm. So you can actually see the confidence interval for the restricted group actually crosses 1, signifying that maybe they could have been slightly worse off in the realms of possibility from being in the restricted group. Excuse me. But we think that that was kind of still a marker for non-inferiority. And as Ethan was saying, there's some explanation that why this could be. So we know that blood that is has been in storage may have low levels of nitric oxide and 2,3-DPG, which may mean that oxygen delivery to the tissues is actually not as optimum as we might expect. Also, there can be some platelet aggregation causing vasoconstriction when patients are transfused. So that could also be a potential explanation. So the benefits, as I said at the start, we're using less blood resources, potentially reduced adverse effects, cost savings and logistical benefits by using a restrictive strategy. So as I said before, the trial isn't powered for superiority, but there may be a trend towards it. So there's that 25% margin may have included some clinically important harm, as I've explained. The trial was unblinded to the therapies themselves just because of logistical. That would have been a bit of a problem, but the actual outcome measures were assessed by independent objective adjudicators. So, and also the patients could be enrolled at any time during the hospital stay. So that could have, it could have been repeated blood draws, or soon after they were given fluids, for example. So that could have affected their baseline hemoglobins. And also the follow-up was only done at 30 days, but there is ongoing longer follow-up. And there also is a bigger trial called the MINT trial happening at the moment with larger numbers. So the conclusions from the study were that a restrictive strategy was non-inferior to a liberal strategy in patients with iron anemia at 30 days, but we would need a larger trial to actually definitively assess superiority. So the last thing I was going to say was just to effect on individual practice. So whether people would consider a restrictive strategy versus a liberal strategy based on the results of this trial, maybe compared to the other trials that have been out there.
Awesome.
I think the main thing that's like it that they tried to say that might be against being restrictive is the adverse events, of which the main one is acute kidney injury.
Yeah.
I just had a thought as you were talking, and I know it's controversial in its own right whether or not you believe in contrast-induced nephropathy, but all of these patients had to be pre-PCI, pre-CAGs to be allowed to be randomised because of, I guess, the interventionalist bias as to sort of post-procedure what they're going to want to do. And I just, of all the things for contrast-induced nephropathy, so N-acetylcysteine, bicarb, statins, and preloading with fluid, the only one that's shown to reduce contrast-induced nephropathy is fluid loading. So I wonder whether the people who got blood in the liberal group almost had a benefit from a renal impairment perspective from the pure fact that they were given a bit of volume. I don't know, but it just came to me when you were talking. But I don't know, some people don't even think it exists, and there's an interesting paper on that recently.
Any comments from anyone else? Any questions? Yeah, Neil? You're on mute, I think.
I know.
Hello.
I suspect most of us won't actually change our practice because we probably are restrictive anyway, to an extent. So, even those of us that do transfuse for these probably use 90. Not 100, and we certainly don't aim at 110. So I think it's difficult to interpret for us. All it probably says is that actually what we're doing is okay, but we certainly don't aim at what their liberal group was. No,
absolutely. You're right. How applicable it is to sort of our population probably is the question, but obviously we don't really necessarily know what goes on the wards, I suppose, is the crux of it. Where we're quite happy with the HB of 70 to 90. I'm not sure how the wards feel about it, having not worked there.
There is a potential study coming up called, bollocks, forgot what it's called, ABLE2, which is looking at post-ICU transfusion. So the inclusion criteria is basically people that have got an anemia, and I think it's HB less than 90, at discharge or decision to discharge from ICU, with a view to whether they get transfused post ICU, which will feed into the ongoing pool of this evidence, but we're not starting that yet.
Okay.
And did you say there was one being done in it?
I'm not sure. I mean, even just asked about just in terms of sort of our niche in ECMO, because obviously we tend to advise all of our referrers to aim for a HB of 10, but we don't really have a huge amount of evidence that makes any benefit, because actually all the evidence we've got is that it probably wouldn't be. So I believe that there is a plan to look at that from our side of things as well, which would mean there'd be one less thing that we can ask you to do. Yeah. Any comments from anyone else who's in the chat or in the meeting? No? No one's here? Cool. Well, thank you very much, everyone. I think the talk next week is, yes, I think John Parker talking about sepsis. So that should be quite interesting, quite topical for everyone. And same time, and we'll put the feedback code in the chat for people to get certificates if they want to use it. Brilliant. Thanks very much.